Hello, it's Jeremiah Cox, welcoming you to another episode of Daily Progress by iiNCHES Foundation. Now, normally, Tim Pickett, the founder and CEO of our sponsor, KindlyMD, is the co-host with Alema Harrington. But today, Alema and I will be interviewing Tim and talking about what they're doing at KindlyMD to create a more complete version of healthcare that is more beneficial for their patients. We'll be talking about what they're doing to revolutionize healthcare and how you can help. Check it out. Let's make some progress today.
Welcome on in to our Daily Progress by iiNCHES Foundation podcast. It is brought to you by our good friends at KindlyMD. For introduction's sake, Alema Harrington, podcaster, broadcaster, mental health and wellness advocate, and SUDC, so substance use disorder counselor. That's way too many things to know about me. We are joined, as always, by the CEO, the founder of KindlyMD. Tim Pickett is with us. So glad to have you with us.
Thanks, Alema.
As a regular guest. And we are joined by one of our producers on the iiNCHES Foundation podcast, and this is Jeremiah Cox, and he will join us for the next 30, 45 minutes, hour or so for this discussion.
Yeah, nice.
And so we're excited for the opportunity. Actually, we typically have a guest that will come in, and we will, Tim and I will ask them questions about their business. This is an opportunity, and Tim, I'm looking forward to talk a little bit more about KindlyMD and a shift that's happening in the health and wellness industry and the things that are going on with the clinics that are under KindlyMD.
Sure.
Maybe you can start by just sharing with us this vision of complete health and wellness and care and what that looks like and why that's so necessary.
Yeah, I think so. I started seeing patients. My background is in GI surgery and trauma as a PA, a physician associate now we're called. Physician assistant is the old name, right? So I worked in GI surgery, trauma, and critical care in West Valley at the hospital. It was called Pioneer Valley Hospital. And when the medical cannabis program in Utah opened up and it became legal to use medical cannabis in Utah, I started seeing patients.
But what year was that?
This is 2020. So I saw the first patient I saw for a medical cannabis recommendation was, I think, January 11th, 2020. Wow. I think I saw 17 patients or so saw that month in January.
Right before the pandemic.
Yeah, right before the pandemic. Who knew? So I saw, and I was interviewing patients and seeing them. And these are patients that patients who are authorized or get a recommendation for cannabis, typically are patients, and we can talk a little bit about, whether there's two sides of this, medical cannabis piece. But there's a lot of these patients who have they're taking a lot of medications. They've tried a lot of different things. Yeah. And there is a huge mental health component to what's happening for them. So I'm doing, at the time, I'm doing medical cannabis recommendations, and that's the only thing that my service was. But I'm seeing and I'm hearing from these patients who need a lot more.
Mm-hmm.
Yeah. And I remember seeing patient after patient saying to me, "You're the first person I've ever been honest with. You're like the first provider that I've ever actually told the truth to. Yeah. I go to my primary care and I hide a few things, or I don't bring up some of the stuff." And so here we are talking about something, right? They want access to medical cannabis, and we just start talking about their medications. People don't know that SSRIs, for example, they're approved for a 6-month course. They're not designed. They weren't never really approved forever.
Yeah, it's not a long-term solution.
But nobody ever tells them that, right? They're on opioids and they're struggling with mental health problems but undiagnosed at the same time. So we go, fast forward a couple of years doing that, growing that practice. Things are going really well, but not feeling like there's more to do. And so we started to see patients and manage their medications.
Yeah.
I knew that I needed to get insurance credentialing
For the medical cannabis
for the medical cannabis piece
component.
and to manage their medications,
Yeah.
because in a cash-pay system, you can't see patients very often. And there are a lot of these patients that are on multiple medications and have a mental health like disorder or something related to mental health. They need more care. You can't see them every 6 months. You can't see them once a year. You need to see them as often as you need to see them. So this insurance piece becomes really important. But there's always this mental health piece that's like bugging me.
Yeah.
So the answer is really just bring the mental health provider into basically the primary care clinic. And that's the vision. The vision is really to build a network of clinics where the PA, the nurse practitioner, the physician sees the patient for their 15, 20 minutes, right? That they manage the medications. And then the mental health provider sees the patient for 15, 20 minutes. This isn't a full therapy session. It's targeted mental health care.
Yeah.
Because you can do therapy separately, right?
Certainly that
right. There's a
clinician
component.
could recommend it.
Of course.
Yeah.
But it's not that our system is set up to be integrated. You have a professional who's good at mental health care, and you have a professional who's good at, like what I'm good at. I'm good at managing medications. I'm good at pretty fast visits. That's how we were trained.
Yeah.
Frankly, that's the only way to make a living, is to keep the visits, relatively short with insurance reimbursement. You build a network of these clinics, and going back to what patients say, right? You're the first person I have been able to be honest with. That's what continues. By doing it this way, we get really high patient satisfaction. We get people off of opioids.
Yeah.
We get people off of their other medications, plus or minus the cannabis.
Yeah.
That actually has become just another tool in the toolbox.
Yeah.
And it really is the mental integration that, like, it's key to the future of medicine.
I've never really shared this. I'm going to share something with you because what you brought up really hits home for me. So in 2000, I'm in a relapse. I end up at a couple of pain clinics. So I'm at two different pain clinics. This is before Doppel was tracking opioid use as closely as they do now. That would be near impossible to do at this point.
Yeah.
But this, the part where you're talking about, I was not being honest with my my doctor, who was prescribing my opioids, and there was things that were being withheld, or I'd share, enough of the truth where I thought, okay, I'm being authentic with this guy. And I'm really trying to sell him on that I need more medication. This is right when OxyContin had hit the market and hard.
Yeah.
And there was, especially in the pain clinics, there was an attitude of, this is what I was told by my physician, was that there's addiction and then there's pseudo addiction. He said addiction is people that truly have an addictive personality and a brain disorder, which as a clinician I understand better now today than I did then. He said there's also pseudo addiction, which is people that have drug seeking behavior because they're not being prescribed sufficient to be able to deal with their pain.
Yeah.
And as a guy that's an addict, I was like, that is like, I'm all for that one.
Yeah,
Like,
that sounds
means I can
exactly
get more
like me.
Yeah,
Yes.
I can get more medication.
Yep.
And if there had been and I don't know that this would have worked for me at that point in my disease of addiction.
And the system.
And the system.
And the system was built
Right.
to structure you to get more and more and more.
And the system was benefiting from
Of
me
course.
being prescribed more.
Yes.
So I really love this what you're talking about, because that needs to change, where we're not pushing certain medications, like even what you're talking about. The cannabis is a tool, but we're not pushing it. right? It's,
No.
Just
And
another,
it is
becomes
just
another option.
Exactly.
Right?
Like you're looking for something to reduce something else.
Yes. Which
right?
is the opioids. In my
Yeah.
case, would have been the opioids.
Yeah.
Yeah.
And the mental health provider does a lot in our system. The mental health provider does an awful lot, but it's not just the targeted mental health care that they do with the patient. So imagine, and let's talk about that for just a second. You're working on reducing opioids, and we want some type of measure. We want to measure pain on a scale of 1 to 10. So I take this many opioids or morphine equivalents per day. My pain scale per day, is a 6 or a 4. I want to keep that score, but I want to reduce my opioids. So you're going to use mental health care. You're going to use targeted mental health to do that. You might not be dealing with the trauma of your childhood or frankly, your injury. You're dealing with some type of, you have an objective outcome. And that's how we measure success. We measure mental health care outcomes by success of whatever we are targeting with you.
Yeah.
So if it is your shoulder mobility and you need to get back to work as an electrician, right? Then we are measuring your improvement in mental health care by your ability to go back to work, not your ability to handle the trauma as a child or whatever it is. We're literally just trying to
specific objective.
It kind of is specific, and you have to do it that way, or it takes longer than 20 minutes.
Yeah.
Right, but it's measurable. That's the other thing about what we do at Kindly that I think is a little bit different in the integrated program. We try not to deal with everything all the time, because that doesn't, I don't know, how many of us have gone to the doctor and you're like, wow, I was just in and out and it's like everything and I don't really understand any of it, right? No, today we're dealing with your elbow.
Yeah.
That's it. You come back in a week, come back in a month, right? We'll deal with it again and we'll just work on it.
Yeah. And we'll check the progress.
Yep, we'll check the progress.
We notice you're bleeding from your head, but we'll handle that next time.
Sure. So then you have this, but then the mental health provider does something else. They hold the prescriber accountable, right? And they help the prescriber, because sometimes we get in a situation where the patient, you've got this relationship with this person. They've got a lot of pain. They may have pseudo addiction or that type of story, right? How do I prescribe less? What's the angle here that I can use to prescribe less or move them on the path?
Yeah.
I'm going to tap my friend in, right? And
Mental health
that's
friend,
literally what they're trained to do, right? They can not only, and then they can come in and they can be that resource.
Yeah, they can
for
recognize
me.
and treat because
Exactly.
that's their specialty. Yeah.
Exactly. So it works out really, really well for almost every condition. I mean, you have from the person who's a misfit in in the system. They don't really fit at the interventional pain clinic. They don't really fit at a normal primary care office. They kind of need a little bit more assistance. To somebody who's super fit, super healthy, who just wants, they think they don't want therapy.
Yeah.
But you come in, how's your life? How's your sleep? And then, one thing leads to another, and you've got something to work on. I describe it as always better health. It doesn't matter where you are on the spectrum.
It's an improvement from where you're at.
Yes.
Yeah.
I think we're always you go to the doctor, not, to see that you're doing well, but you're always asking, well, what could I do?
Yeah.
My cholesterol's borderline. Most of the time we're going to say, yeah, you don't need to do anything. But you want something to do, right?
Yeah.
Tell me what to do.
Yeah.
And the mental health provider can really help with that, because a lot of behavioral change,
Yeah. For sure.
comes from that side of it, right?
Yeah.
Not from my side, right?
Yeah.
It comes from your side.
Yeah, it's happening here.
Yes.
My inability to make the significant necessary changes. It's like academically, I understand it completely.
Totally.
Right. And I might even have some, self-loathing that I know what I need to do, but I can't do. But that's happening in here, right?
Yeah.
And that needs to be overcome here and some of it here.
Yeah.
And the mental health provider is the one that can identify that and say, okay, there's some trauma here that is unresolved, that if we can treat that,
we'll get somewhere.
We're going to get somewhere.
Yep.
Yeah. No, I think that
and those small steps make a big difference in the long run,
difference.
Right? So that's how this all started, and it works so well for patients that we decided I met somebody who gave me this idea to take this company public, and there was a lot going on at the time, and we were doing really well and growing, and I thought, this is just so crazy. I can't deal with this. A year later, that same person came back to me, said, "Hey, let's go have a beer. Have you thought about what I talked about last year?" And I remember talking to him, and the guy's name's Gareth Sheridan. He's the CEO of a NASDAQ traded company that develops. They're developing a fentanyl patch with a coating that you cannot abuse it.
Yeah.
So you can't crush it up, you can't smoke it, like it's an anti-abuse coating.
Yeah.
So he's kind of in this pain space, but he's like, your message is so much bigger as a public company.
Yeah.
And you can share the value, like the growth value as a business with more people that way. So you just have the ability to scale so much bigger. And it made a lot of sense.
Well, and I can see that appealing to you, because at one point you're sitting there and the light bulb comes on and you're like, what I'm doing as like primary care or as a clinician is incomplete. Is that kind of what?
Yes. Yes.
And you thought that there needed to be a more complete care solution that wasn't being addressed according to the existing model today.
Yes.
Yeah.
It's exactly right. But how do you create that model inside a system? So I've always been a believer that if you want to change things if you really want to make a change, I mean, we live in America, you vote, you make a change, right? That you don't overthrow things, right?
Well, some people do.
Yes, and some try, right? So, but I believe that if you're going to legitimize cannabis as a tool, if you're going to legitimize this integrated behavioral health system, then you have to scale it inside the system and just prove to the system it's going to work.
Yeah.
And then the system will adopt it because it worked.
And not many other people or clinics are using this combined approach where you've got primary care and behavioral health weaving in alternative medicine. I don't know anyone else who's doing that. Just putting together mental health providers and prescribers is something that a lot of companies have tried. Like I understand Select Health and IHC have tried it and then maybe stopped it. There's other clinics that have tried it and stopped it. It's not easy. The billing is not easy. The compliance isn't easy. Just the flow of patients isn't easy. So logistically, there's a high barrier to entry. Yeah.
Add opioids to that, right? You have a patient population that sometimes is a little bit more difficult, a little more demanding. They need to be seen a little bit more frequently. And sometimes those visits end up lasting a long time, right? You're scheduled for 20, 30 minutes and it's 2 or 3 hours because that's what you need.
Yeah.
Right? You add cannabis to that or alternative medicine, and it just throws everything to just a really, really high level of not only barrier to entry, you would call it in business. And so we don't know anybody. Like you can't find anybody who specializes in alternative medicine, getting people off of opioids, integrating mental health care with the physical health care. It just doesn't. Like I couldn't say when I applied to the NASDAQ that we're the only one. We just couldn't find anybody.
Yeah.
It doesn't. And providers, I've talked to providers, provider after provider just refers us the patient because they don't want to deal with it.
It doesn't meet the same criteria that they're used to according to their flow.
Exactly.
It disrupts their flow.
Yeah, it does. It disrupts the flow. It's something to learn that's difficult to learn. You've got to have a lot of training around it. So it's a big opportunity for companies, I think, who are willing to do the work to get into it. And I think that too. Like, we need more companies that are like KindlyMD.
I can see that.
To do this. We really do need more. And there's room for plenty of us to do it. The system just isn't necessarily built for it. It's starting to come around. But
things that are better typically do find a way of coming around. But the thing that gets me is that it sometimes takes too long. And in the middle of waiting for someone like KindlyMD to perfect the process, people aren't getting treated the way that they need to be.
Yeah.
So the public company allows you a better platform for this.
Exactly right.
Yeah.
Yeah, you can grow. When we grew in Utah alone, organically, profitably, I have a background, like in 2008 when the world ended the first time and the housing market crashed, I was in construction and lost everything.
Yeah.
Remember that?
You needed to see a mental health provider.
We switched over to Y2K.
Y2K.
Because we were around for that, so that was when it ended the first time.
Oh,
so
yeah, it ended the first time.
And
in
then
08 it ended.
Let's get into that.
That's right. That's right. And then you had COVID.
Yeah.
But I cut my teeth on losing everything financially in 08, and went back to PA school, and during that period of time. So when I started this business, we were just running it organically and just growing as much as we could at the time. Being a public company gives you access to capital, right? It gives you access to grow, spend money on marketing, spend money on hiring, spend money on acquiring different, businesses to overlay this system onto. And it also, like I said, it gives people a chance to participate in the idea as shareholders.
Yeah.
Right? You don't have to participate as a clinician. You don't necessarily even have to participate as a patient if we can't get to you. Yeah. But you can participate as a shareholder. You can say, I believe in this thing and I want to help it move forward. And so, I'll become a shareholder.
Yeah, that's one of the items where some applause is necessary. From what I understand from people that work with you on a regular basis, obviously this was not an easy feat becoming a public company. It was actually very arduous. There was a lot of hoops to jump through.
Yeah, but I need to be a patient of Kindly.
For the
mental health aspect of it. Yeah, it's a traumatic. And being a very small company and getting on the NASDAQ, it takes years to do. It's extremely expensive. But if you want to be in the game, you can do it. If I dedicated my life to this, and we did get it done. It was touch and go for a while, right, to get it over the line. But it's been really exciting, and it's been exciting to tell the story, like telling the story here, or being able to contribute to a podcast, or beyond just the patient care. Because the patient care is important, but like I say, we need more companies that are willing to do this. We really, frankly, need more physicians that understand this is an option for them, right? You can hire a behavioral health person. You can come to a company like ours, and we can help, right? You learn how to do it, learn how to bill it. It doesn't have to be us who takes care of everybody, but we've got to still take care of everybody.
Yeah. But you're restructuring the system. You said something I thought that was interesting about some larger medical hospital type of institutions, and I almost feel like they may have tried to implement this, but they were already too big. So they had already been built differently, and now they're trying to change it. This is being built from the ground up.
Yes.
This way.
Yep.
And the change. you look at the larger institutional hospital type of programs that it just is too much to try. You can't change it because it's already too ingrained.
It's already too ingrained.
Right.
Right.
And
the hospital system
yeah.
is just, it's built for a certain structure.
Yeah.
The insurance system that pays us is built in a certain way. The codes are built. Like, it is so structured that changing it has been, I mean, it's
monumental.
it's monumental. And it's going to take some time, right? Like, we're not going to change it overnight, even though just because we're public and just because we're traded on the NASDAQ doesn't mean, I'm not Apple, right? Like, we're just not that big.
You
We're
should
not,
eat more
and we're
apples.
not, we're not Walgreens, right?
Right.
With this much distribution. But the other thing we're doing is we're tracking the data associated with what we do in order to legitimize this program. So one of the big things that we committed to early on was, and this comes from like interviewing patients and finding out, okay, what are you using? What are your prescriptions? How can I tweak that use of prescription medication or cannabis to lower just by 10%? We're just going to lower it by 10%. What are we doing over and over and over? What are we saying over and over and over that is affecting the outcome? And being trained in medicine, we don't use any medications. There isn't a procedure that doesn't have a lot of evidence behind it, a lot of studies behind it, and a lot of algorithm building, right? Especially as a PA. So as a PA, we are trained. I always used to tell my students this, you're trained not to kill anyone and when to call for help. Those are the two things you cannot remember. But we're very algorithmic. Being a PA, we take care of about 85% of what a physician takes care of. But that 85% is very algorithm based, right? It's the 15% that you really need that specialized education for. We take care of the bulk of it.
Yeah.
So I knew that, and I know that if you want to legitimize this integrated behavioral health program, then you need a lot of data. Because then you can go to big hospital systems and say, you need to do this, and we'll just show you we'll show you the data.
Yeah.
And we'll show you the method.
Create it and construct it. They just adopt
They can just adopt the program.
Yeah.
You want to legitimize medical cannabis and use it as a tool in the hospital system?
Show me why.
Yeah.
Why should I do that?
So in GI surgery, where I worked at Pioneer, I would have patients come in with acute pancreatitis. Super painful. Really like mid-abdominal pain, radiates to your back. You can't eat, really nauseous. And the only solution that we had, and that we still have, is don't let them eat or drink anything. Put them on IV fluids. Give them a bunch of opioids, which don't help their appetite at all and doesn't help their GI system.
No.
Everything slows down, which makes their it doesn't make it better.
Yeah.
And a bunch of Zofran for nausea, which constipates you even worse. Cannabis is the perfect medication in that scenario, but there is no proof that it would work. There is no algorithm for using it, so it's never going to be legitimate.
Yeah.
So we're collecting all of the data that we can. We've spent a lot of money on developing a data lake that will house all of this data. So we track not only what your lab results are, what your prescription medications that you take, all your clinical notes, all the behavioral health notes, right? All that paragraphical information. We see what people purchase at the dispensaries. Here in Utah, we have access to that. We pull all of that data in so that, and now with AI, we can use AI to go through that data and organize it a little bit and see what comes to the top. So we can adjust you call it precision, a recommendation engine, but it's more precise.
Yeah.
Patients with these conditions that tend to have these mental health things, we tend to say this, and it tends to this outcome. So when patients come in, and they start describing this and you're charting it, then the computer can kind of pop up and say, hey,
I recognize this.
I recognize this from the 10,000 patients that we had before, eventually hundreds of thousands. You get that kind of real world data, and that's what will change the system from the inside.
Yeah,
that's
I
the
like
only
that.
thing that will legitimize.
Empirical data
Yeah.
validates the
Yes.
fact that this method of treatment actually works instead of it just being an assumption.
Exactly.
Yeah.
And you don't need the chemical mechanism of action to make that happen. You just need a massive amount of data.
Yeah.
Right? And they're using it, like, you think about it, like in your background in sports, think about how much data has changed
Oh, yeah.
sports and training.
Yeah.
And it was just collecting it all and seeing if you make this many free throw shots every day,
Yeah.
you tend to increase by this much. And
Yeah.
it just,
it's
and
such
it just
a
works.
huge part of the NBA, the NFL, Major League Baseball, NHL, all of that data that is being collected, and now in front offices across the country in different sports franchises, they're using that and finding obviously success. Otherwise, they'd stop using it.
Of course.
But there are. I mean, it's intricate to the point of when a player gets a tip in or gets a blocked shot, what is the result after that? Like, and it starts.
So
a fast
next
break,
level.
right? It's insane for
Yep.
a guy that's coming from my generation. All of this information that is out there that is valuable. I mean, it's got a high value in that marketplace.
So with mental health care, I think that's something that I haven't seen a lot of, but I'm sure it's out there. And that is, how is these, what can we do around mental health care? I know the military does a lot of research around, PTSD and, how do we handle really stressful situations? And I think that's kind of next level in just general medicine, is taking all of this information that we're giving it, not just the labs, but taking what we're saying in the room, taking what the clinician is charting, and then creating just a little bit of a recommendation so we can help the clinicians and the patients point themselves in the right direction. A lot of that comes from patient-reported outcomes too.
Yeah.
Because we're giving the system so much more data, right? With the wearable, I mean, I got my your the Whoop, your sleep.
By the way, you've been sitting too long.
Exactly, it's probably going to vibrate soon and tell me get up. So the data is a huge part of our business, but again, back to this public thing, we don't track the data if we're not public, because we wouldn't have the money. Right. We wouldn't have the resources to develop the protocol or develop the system without that capital.
Yeah.
So I think in the future we're going to be able to do a lot of really, really cool things at Kindly, regardless of how big we get or how small we stay. We'll be able to really make a difference for the people that are involved with us as patients. We're only in Utah now, but hopefully this expands, piece by piece by piece.
Yeah. That ties into our mantra over at iiNCHES Foundation for Daily Progress. It's like, look, you're not going to solve the problem today.
Yeah.
But if you do accomplish a few inches of progress by validating the data, by capturing more data to validate more data, to the point where this becomes legitimized because the outcomes prove that your different way of doing things is working.
Yes. And it either is going to prove what you're doing is working, or it's going to prove it's not helping.
In which case you adapt and you try something else.
Exactly.
Because I'm sorry, but my humble opinion is that there are a lot of people continuing to suffer in an inferior system and model because there's only one pioneer out there right now that's willing to challenge the existing model.
Sure. I can see that.
Yeah.
Yeah. There's just so many, and we see it every day in our patients, right? You get a new patient and the reviews on Google or the reviews on, our review system, They say that over and over. Wow, I finally found somebody. I finally am able to talk to somebody. I'm finally able to do this.
I actually feel heard.
Yeah, that seems so crazy to me.
Yeah.
And maybe it's because I felt like I was always a clinician that allowed patients to
that listened.
Yeah. A patient comes in and they're a, couple of pack a day smoker. I'm not going to, I don't know. I grew up with a family that smoked. Maybe you're just not done with it yet, and
Yeah.
we'll deal with that later.
Yeah.
I addicted to people. I gave people enough opioids after surgeries that I would tell them, "Hey, look, we're going to have to deal with this later."
Yeah.
Yeah.
Right? Because you're going to need this much drugs just to function.
To manage your pain.
To manage your pain. I mean, we cut
Temporarily.
people open all the way, and it was just nuts. And that's what those drugs are for.
Yeah.
And then you just have to deal with it later. But like you said, you're not going to solve the problem today.
But you're really remiss in your responsibility as a medical professional if you don't look for better ways to do things that result in better outcomes. Otherwise, you're just part of the same norm that cycles and cycles without any improvement.
Yeah, we're not making people. Finally, I think there are some drugs out there that are making people healthier. And finally, I guess maybe I say that because we see it in our clinic, right? We see people change. Oh, I mean, let's talk about weight loss for a minute.
Yeah.
As far as a drug that is really, really making an impact on people's lives, imagine now coming to KindlyMD and you get the drug service, right? You get the tirzepatide or semaglutide injections, but you also have the mental health care alongside it. So you can deal with the root cause or the solution.
Or the side effects.
Yeah, or the side effects. There's a lot of issues, not only just getting onto those drugs from a mental health care perspective, but now you have people coming up to you saying, "Wow, you're losing a lot of weight. Are you on that shot? Or you're losing a lot of weight. Are you okay? Are you sick?"
Is it okay to lie about that?
Dealing with that is all up here.
Yeah.
It
right?
is.
That's all mental health care. So in our weight loss program, it turns out to be a really great thing. Not feeling guilty, being okay with the new, your new self.
Yeah.
Being okay staying on the medication because that's what you need. And you can't, people will lose 50, 60 pounds on those medications. And then they'll say, "I want to get off of it."
Yeah.
Well, the truth is, it's okay if you stay on a low dose for a long time, but that's all mental health care,
Yeah.
right? So integrating that has been fascinating,
Oh, I can imagine.
and it's been great for our patients. We changed a ton of lives with our, with patients that are on weight loss programs.
Well, even going back to pain management, when OxyContin came out, it was supposed to be prescribed, and at the same time, you were supposed to be getting counseling.
Right.
That was the way that it was supposed to work initially.
And I'll bet in every one of their charts, it
Yeah.
says recommended mental health care,
Yeah.
recommended therapy.
Yeah.
Right.
But who followed up on that?
CYA.
They did not do
CYA.
that, right? And so what you're doing is groundbreaking in the sense that it's part of the integration. It's integrated into it.
Yeah. There's
Right.
no choice.
Yeah.
It's part
Right.
of the same day, is it?
Because the things that you're talking about with people that weight loss is certainly a big deal. Pain management is a big deal because there's significant changes that happen, especially
Right.
with the weight loss. You become a new person.
Oh, yeah.
And so how do you deal with that mentally? And you might and probably will need some help to address that from
Yeah.
a mental health professional.
Well, and you don't see it. You just think, "Oh, well, I'm gonna be off my opioids, and so I'm gonna be happier."
Yeah.
Well, there's always stuff,
Yeah.
right? There's always stuff, and there's a generational thing too, where introducing somebody to a mental health professional in a short 15, 20 minute, just hello,
Yeah.
right? It's It's not invasive. We're not going to
less
talk.
intimidating.
It's less
Yeah.
intimidating. It's just part of the protocol. We're going to introduce you, and then when something happens, you have a resource. You're like, oh, I need to go back there, and it's okay that I talk to somebody. And that's been a big deal for, well, it's for Gen X men to the boomer guys, right? Like, it's this generational thing that we're just not ready to talk to a therapist.
Yeah. We're not ready to ask for help.
Right.
It's not in our, it's not the way we were raised. It's very counterintuitive for that segment of the population.
Yeah. So that's been, I think, introducing it has just been a side benefit to a lot of our patients too, in that non-invasive way,
Yeah.
right?
Yeah.
It's not threatening. It's pretty cool.
I
A
think
lot
it's
of
awesome.
a lot of people will come back and they'll certainly ask to see the therapist first, right? Like, that's the bulk of the visit, and then they get their prescriptions kind of managed, and they're on their way.
Yeah.
And we like it that way.
I
becomes
think
very
that's
efficient.
Fantastic.
Yeah.
To be honest with you, I think that's a great approach.
We like the functionally, when you come in as a new patient, you typically see the mental health provider first. That it tends to work a little bit better, and it breaks the ice.
Yeah.
When
Right.
did you identify that? Is that something that occurred month 7?
There's a
or-
couple of things that happen. For me as a clinician, I'm used to doing the whole, like, I was trained to do the whole visit. So it's hard for me to shift and to bring them in, because I want to complete the visit and then be done.
Yeah.
And so it was hard for me to bring the mental health provider in just functionally.
Mm-hmm.
So I always have liked the mental health care part to go first. That just worked for me. There are other providers who like it the other way. They like to go in first. So that it tends to be provider specific.
Interesting.
Like you said, Alema, though, building the system is much easier than implementing the system.
After the
So
fact.
when I have a new provider, super easy to get them to integrate. But if you have an existing provider who's been used to a system, it is hard.
Yeah.
It's hard. Yeah. And you really have to, you have to incentivize them. You have to tell them that this is the way this is the way it is.
Yeah.
Right. Sometimes you just have to make them do it.
I just think of my own personal experience recently. Over the last 5 years, I've had 2 back surgeries. So I go and see my neurologist that's going to perform my back surgeries. Getting ready for a surgery or checkups after. There's always somebody that takes me from the waiting room back, and then the doctor will be here in a little while and might take my vitals. Right.
Right.
If that were the mental health, the person, the
Yes.
clinician, then could handle those things prior to me meeting with the doctor, and anything, some questions I might have about my mental state, or I'm a little concerned about this. I'm worried that the doctor is going to be frustrated with me because I had to refill early, whatever the case may be.
Yes.
But I can address that with somebody who's not the doctor, right? And then that person really does have
they become
best
your advocate.
interest, mental health wise, in mind.
Yep.
Yeah.
And they're asking questions. They're asking questions that are different.
Yeah.
Right? Do you have support at home? Do you have, what's
he
this
would
going to
never-
look like?
You would never ask that question.
Well,
No, I'm just kidding, Tim.
right? But that's but it is that way, right? Like, how are you feeling about not being able to go back to work yet?
Yeah.
Right? How is that really affecting you?
Wow, that's
Are
a-
you sleeping?
Yeah.
Right? Or is this really
It sounds
bothering
so
you?
nurturing.
Yeah, it does. It sounds so nurturing,
Yeah.
but these are critical. That affects the care.
Yeah.
No
Right?
question.
Because not being able to go back to work actually does have an impact on your mental health and your sense of self. And to be able, and the doctor's not there to address that. My neurosurgeon certainly is not there to address that.
No.
But if I have the mental health, component, and I can address that with them, it's like, man, I really am feeling some shame that I'm not going back to
Right.
work, and my self-worth is, in the tank, and I'm not sleeping, or I'm sleeping all the time.
Yeah.
Those kinds of things can be addressed by the mental health professional.
That particular piece, especially with like workers' comp or surgeries or acute injuries, where you're either getting better, you're staying the same, or you're getting worse, that mental component, and the doctor's going to know if you're on the right trajectory,
Yeah.
right? You're 6 weeks after your back surgery, you typically should be here. If you're not, then why? And if it's not a physical problem, then it's the mental health piece. And sometimes you're just not going to get any better.
Mm-hmm.
And now it's just mental health care. And like, how are we going to live with this?
Yeah.
Right?
Yeah, this is my new norm.
Yeah, this is my new normal. And we're not getting any better. Yeah. So you've got to have somebody in there. Or those patients end up costing the system an awful lot of money.
Yeah.
They cost a lot of time in the like functional clinic in the business. And they don't have high satisfaction, right? So you're doing nobody a service. Yeah. Everybody loses in those situations. But if you have somebody there and it's built into the system, then you save everybody money. You save everybody lost work days.
Yeah.
There's a cool program in Colorado that's Comprehensive Outcomes Management Technology, COMPT. A guy named Scott Primack, who developed a system that is similar to this, right? And they don't use mental health care in their clinic. They use it as a telemedicine basis, but he takes care of athletes. And it really comes down to, are you getting better? Are you staying the same? Are you getting worse? Are you on the right trajectory? And then the patients help report that. So there are pieces of our system, right, all over the place.
Yeah.
But you're trying to perfect the model through data.
Yes.
Yeah.
Perfect the model through the data, and then really just take care of the patient.
Yeah.
Right. Do whatever is right for the patient. That when you do the right thing with the patient, for the patient, your business will succeed, right? The patients do well. It'll work out.
Well, and the thing that keeps hitting me is more people all over the world deserve that same level of care.
Yeah.
And so from a public company standpoint, I'm looking at this as someone that wants more of this, like for my folks that live in Arizona, or for
how do we
family
get
that I
this
have.
down there?
Exactly.
Right? Yeah.
So what are some of the plans to expand and to take the public company and allow more clinics and more providers to fall into this new mechanism?
There are a couple of ways that we're looking at expansion with and without a lot more capital. So acquiring clinics or acquiring interventional pain clinics and then overlaying the system has always been something we've been looking at. Another option for us is really doing this in a remote way. So we're looking at, and we're testing this right now in one of our locations, having the mental health care be telemedicine as a way to bring this to other clinics out of state earlier than we can get there.
Yeah.
So
right?
they use
Physically.
your mental health through telemedicine as an addition or extension of what they've got in-house.
Correct.
I like that.
There are some companies that have done this, not quite in our model, but we believe that this can work in a cost-effective way and still get 90%. If I can get 85, 90% of the benefit, and I can overlay this in your mom's clinic in Arizona without having to go and buy their clinic and do all of that, then that works. And I can scale that much, much quicker and get a lot more access to a lot more people just on the mental health care side.
Thank you, technology.
Exactly. So we're currently studying that piece in our Ogden clinic right now to try to. We have to perfect the model a little bit before we overlay it, and we really kind of quote unquote go to market with that model. But that's one way that we're really honed in on expansion, like in the short and medium term, 1 to 2 years.
That makes great sense. I was just talking to my brother-in-law, who is he's working with a group that sells these Zoom systems.
Yeah.
Where it's a really high quality display and really great sound system. And he's like, there's so many applications. We just installed these many SoFi banking rooms so that they could have these high powered meetings over video conferencing.
Right.
And I love the idea of considering having a room like that in all these clinics across the world where Tim Pickett in Utah can offer his advice and his professional opinion on someone sitting in the Netherlands, as an example. I just love using technology to manage costs on one hand, but provide better, more complete care through what Kindly's building.
Sure. And I think for pain docs specifically, there is quite a bit of interest, because all interventional pain docs have a subset of patients that don't, they've done a procedure, they've maybe done 2, they maybe have been around to a couple of other clinics. And what do you do with that patient? That patient is really well suited to a mental health intervention, but they are going to need their opioids managed.
Yeah.
Right? So if you can apply the mental health care at the meet the patient where they're already at, you don't have to fire the patient from the clinic. You can answer the question, why did you feel early?
Yeah.
The provider who's prescribing the opioids can feel like they're getting a little bit of their liability covered, because they have a second opinion essentially right there in the room.
Yeah, reinforcements.
Otherwise, that patient gets fired from the clinic, and then they're searching around, and then they're in worse shape, or they're buying drugs on the street.
On the street, which is a very common, storyline that I see, with clients that I treat. Injury, prescribed opioids, got cut off. This is my story. Eventually, when my OxyContin was cut off, I'm buying heroin at Pioneer Park. So, and that's a common, that's the path.
That is the path.
Even as I look at what we're doing, and we're gonna shut down the fentanyl
trade. Right.
It's like, we better have a solution that is going to address all of the people who are going to be going through withdrawals, because if we don't treat that mental health component of it, then we got less fentanyl, but our heroin,
it'll exchange for something else.
Exactly.
It'll get exchanged
unless we can address the addiction side of it, the brain disorder that is addiction. So
and that piece of it, I think Kindly can really put a dent in. And from a remote standpoint, hey, if that's going to work and that's what people are using, I think we're more and more used to that too.
We are, since the pandemic, certainly.
Especially. Yeah. And providers in the pain space want it. So that's something we're looking at, and then continue to collect data. So we're kind of at the point now with our data program and our data project that we can collect all of the data now. We need an awful lot more to really make it useful and potentially monetizable, right? We could lease anonymized, always anonymized, HIPAA compliant data.
Sure.
But we need an awful lot more data. So we need to get bigger to make that, to build the algorithms.
One last question for you, then, that this is related. This is a journey for you, and going public with the NASDAQ was certainly, I'm sure, had its challenges. What has kept you going through all of this? Were there times when you were like, because I'm looking at the larger institutions that tried to implement this and just said, okay, we can't do it.
Yeah.
Like, what has kept you going through all of that?
Honestly, every month, our clinical director just yesterday posted a bunch of reviews. And it just comes back to the people that we take care of. They really need this. And at the end of the day, whether we grow to be $1 billion company and help millions and millions of people, or whether we stay in Utah and we keep doing exactly what we're doing now, we just take care of, I went to school to take care of people. That's what we do. Yeah. So when things are tough, and they definitely are, when the medical cannabis program legislation doesn't work out, or somebody changes it, or there's bad actors in the system, man, it's frustrating. And you just want to stop doing it altogether and just, I don't know. Sometimes you're like, I just want to go back to the ER, you work a shift, take care of some people, sew up some, somebody who cut their arm
That's easier
and
than
then just go
changing the
home.
world.
Yeah.
Right? That's just so much easier than changing the world, I guess.
Yeah.
But at the end of the day, these patients really need us, and they appreciate us. We do make a difference, and that's the reason why we just kind of keep grinding on and figuring out a way to do it. If it's not us, no one's going to do this.
Yeah.
I feel like too.
Yeah.
Like nobody's going to say, "Hey, let's get insurance coverage and be honest about cannabis." Right? We don't know anybody who
doing
figured that out, right?
Yeah.
And our COO somehow built relationships with the insurers and worked it out.
Yeah.
And now we do it. And who's going to work on these providers and teach them how to use that integrated model? And we just keep doing it. But it really does come down to the reason is the outcomes are better. This is how it's supposed to be done. We're believers.
Yeah.
So we
People are actually getting better care.
People are actually getting better. The outcomes are better. The data shows it. Yeah. So you just keep doing it.
Yeah.
Yeah.
See,
We'll figure it out.
Get those reviews, and it's like, okay, all right.
Yeah.
I'll
I'll
go
do it
another
again.
day.
Yeah.
The data
Let's
doesn't
just go
want
another
day.
day.
Yeah.
It's how you in the mental health care
Yeah.
space, right?
Yeah.
10 people fall off the wagon
Yeah.
and they go back, and you're like, and
Yeah.
you just kind of keep
Yeah,
doing it.
because there's that one person that, even if it's the second, third, fourth time that they've been
Exactly.
through treatment, but they finally have a significant period of clean time, and you run into their mom or dad or their spouse on the street, and it's like, hey, thank you.
Yep.
It's like, okay, I'll do this another day.
Yeah. Okay. Okay. I better
That's
keep doing it
rewarding.
because that affects somebody else,
Yeah.
affects their kids, and that's how you change the world.
Yeah, because the burnout is real, the struggle is real to keep going, and so as a person that has lived that and then deals with that population very closely, thank you for continuing to grind.
You got it.
Because we need you, and recognize it's not an easy thing. So Tim, thank you for that.
Yeah.
Jeremiah, thank you for joining us.
I have one more thing I want to ask.
Okay.
As someone that really, really wants to get behind the growth and expansion ability of KindlyMD, from a public company standpoint, how do I get involved? What do I do?
I mean, you go out, you search KDLY on Yahoo Finance or your brokerage account, right? Your Schwab account.
Just buy some stock.
Just buy a few shares. Participate that way. Easy enough, right? Put us on your watch list. See what we're doing. Follow us on social media, all those other things, and that's just how everybody can participate a little bit, right?
Yeah.
Whether you can see us or not.
No one's disqualified.
Yeah, nobody is disqualified from that.
Because you are a public company.
Yeah.
And you have that level of scrutiny and oversight that a NASDAQ company requires.
Yes, which is very significant. And but it makes it fun. It makes it fun because we have thousands and thousands of people who are involved in that way, and who really believe in that disruption, right, of the system and helping people.
And it needs disrupted. I mean, I'm with Alema. The opportunity to flip things on its ear and change the script is just so necessary. I mean, I think of someone that maybe has lost a loved one to an opioid overdose, and I think about the negative stigma that currently surrounds marijuana or cannabis or THC.
Sure.
And it's like if it was my loved one that died from that overdose, I would have 100% looked into those alternative medicines as a way to prevent their death.
Yeah.
Because I'm sorry, but for all the right reasons, this deserves more attention. It deserves more thought. It deserves just more funding, frankly.
Sure.
The data that you're collecting is so necessary. But if we could save a life because they opted to follow KindlyMD's program and have that behavioral health component where an alternative medicine was prescribed to wean someone off opiates, and that resulted in their long, productive life, isn't that what we're supposed to be doing anyway?
Yeah.
I think so. I think we all agree.
Yeah. That is how we make daily progress.
Yeah.
So thanks for tuning in to the iiNCHES Foundation Daily Progress Podcast, and we will see you next time.
Stay safe out there.
Hey, thank you for watching and listening to our Daily Progress podcast today. Special thanks to Tim Pickett and all the folks over at KindlyMD for the work that they're doing to improve healthcare, to revolutionize healthcare. Check out kindlymd.com, visit nasdaq.com and search stock symbol KDLY and learn how you can contribute to the growth and expansion of KindlyMD and the work that they're doing to improve healthcare for all of us. Thanks to Alema Harrington, our host. We welcome Tim Pickett back next time as co-host. And if you have someone that you want us to interview or a topic you want us to tackle, email progress@iiNCHES.org. That's progress@iiNCHES, spelled with 2 I's.org, and tell us about it. Tell us who you want us to interview, what topic you want us to dig into, and let's make some progress. Let's get better, even if it's just by inches daily. Because remember, inches become miles after a while. See you soon.